talk today, the starting of TOSSM 2023, let's go at the first ICL session, which we will talk about the dysplastic hip. My talk will be the relevant history and physical examination that related to dysplastic hip. Okay, here's my content of talk today. Okay, as we know, the dysplastic hip is the common cause that leads to osteoarthritis in young patients. COHESES in 2011 report that DDH is the first most common cause of the primary cause in the osteoarthritic hip in the young. The second common one is the FAI, as we know. So it is important for us to detect this condition in the young patient and adolescent. The incident and natural history. The incidence, it is still unclear because the spectrum of disease in some patients will be asymptomatic. The estimate prevalence in US is about 0.1%, and in Danish report 4.3 in men and 3.6 in women. In Chinese population report 0.75% in men and 2% in women. The natural history is very varied because in some patients it's asymptomatic. They will come to see physician in the 5th decade of life with the radiographic change to osteoarthritis around 25 to 50%. So let's find out what is the clue on history and physical examination that leads us to suspicion of the dysplastic hip. The pathoanatomy of the dysplastic hip is occur on both acetabulum and proximal femur. As we know, the dysplastic hip, it is the deformity that's developed into the dysplastic socket. It has problem in size, shape, and organization too. And also the proximal femur maybe have more anteversion. And the labrum may become hypertrophy in this kind of developmental dysplasia. There are some interesting terminology that's used in dysplastic hip. The first one is the symbiosis. The symbiosis in the term of biology is mean the interaction between two organisms that provide advantage on each other. It can imply to dysplastic hip in the term of femoral head and acetabulum that during their development, they depend on each other to form well and have good function. The second one is acetabular limb syndrome. This term is proposed by Clower in 1991. This term means the spectrum of clinical presentation of the dysplastic hip before it turning to osteoarthritis. Maybe when we read about the literature, maybe we can find this terminology. Okay. Go for first, on the history, we have to look for two key factors. The first one is the risk factor, and the second one is the clinical presentation. The risk factor for hip dysplasia since the newborn or infant, there are three main risk factors. Is accepted that is significant for dysplasia. The first is the bridge presentation. The second one is the female sex. And the third one is if there are any positive family history of the DDH, there will be higher risk for hip dysplasia. And some report that the left side will predominant in DDH. Okay. This literature in 2012 report that breech delivery, female and positive family history for DDH have higher odds ratio for developing the dysplasia. And for infant and newborn, the odds ratio is very high or highest from this report in physical examination that show clicking the hip on examination. But this is for the infant and newborn. It is important to screening for the DDH since birth. Generally, the pediatrician almost always take a physical examination on the infant. As we learn as a medical student, we learn the Ortolani and Barlow test, right? If in the suspicion case, the radiographic and sonography must be used to confirm the dysplastic of the hip. Despite we try to screen for DDH, there are some patients that we cannot detect at the infanthood or since newborn. This patient may be grow and have asymptomatic and come to see us and when they grow older. So the clinical presentation in adolescent and adulthood may be the first step of detection of the dysplastic hip. The most common symptom is groin pain or hip pain. And the pain will be the insidious onset mostly. The pain could be sharp and sudden pain, depend on the activities. The other thing is the patient may be complained with snapping, locking, or clicking, and may explain the instability. The instability itself may be, can be explained like the unexplained fall, or patient will complain that they have unstable hip, but that not actual like the giving way. The next important thing we have to ask the patient is the related back pain, spine pain, and the other complaint may be abnormal gait or decrease the strength of the hip. Okay, the literature in 2011 report the patient who underwent periacetabular osteotomy due to dysplastic hip support that evidence. The clinical presentation more than 97% is insidious onset, and they will have moderate to severe pain on activity of daily living, almost always groin pain, and maybe plus the lateral hip pain. On the physical examination, they can detect the limb, positive Trendelenburg sign, and positive impingement trace. This one is interesting. Okay, I will talk on the next slide about the special test. Okay, the physical examination that related to dysplastic hip, we have to look for 6 components. But in childhood, as we know, the physical examination different in the age of newborn or infant. The first newborn we can detect like ortholani and Barlow taste, asymmetrical gluteal thigh fold, or Gallier C-side. When age more than 3 months, the limitation of abduction may be the most reliable size. And when they grow into the ambulating child, the Trendelenburg gait is more strong evidence. But the lateral dysplasia is more challenging. Okay, this is the 6 components that we have to look for in adolescent and young adult who suspicion of the dysplastic hip, which are gait assessment, leg length, muscle power, the range of motion, spatial taste, and miscellaneous wizard look for hyperligamentous laxity and back and spine pain. Okay, the gait, most common gait pattern that we found in dysplastic hip is the Trendelenburg gait or Trendelenburg taste. It is unable of the patient to maintain the level of pelvis, which caused from the abductor weakness. The leg length we have to measure on both sides. It may be equal or unequal depending on spectrum of the subluxation or dislocation of the hip. Normally we measure from ASIS to the medial malleolus and record the range of the both sides. The muscle power commonly found that the abductor of the hip will weak. We can perform this examination on the lateral decubitus position and ask the patient to abduct and resist us to test the power. The range of motion can found in normal or increased range of motion or stiff. Normally when we examine and found the increased range of motion, it will common in increase of internal rotation due to excessive anteversion of the femoral neck. And stiff may be found in the advanced stage of the osteoarthritis. Normally it should be a limit of abduction and external rotation. Okay. The spatial test composed of 2 spatial tests which are impingement test and apprehension test. The first impingement test is as known as the failure test. We can examine on supine position, make the hip and knee flex to 90 degrees, and plus internal rotation. If the test positive, it will make a patient feel groin pain. Okay, the apprehension test we can perform in both maneuver. The first one is on the lateral position. Bring the hip to hyperextension and plus the external rotation, or at the lower pictures, we bring patient to the lower end of the exam table and do the hyperextension plus external rotation. The positive test will be feel discomfort or instability at the hip. The other thing that we have to check is the hyperligamentous laxity condition of the patient. The common use is the Brighton criteria. We have 5 components, which are 1 point on each side, and the palm to fore is 1 point. So the total of the Brighton criteria is 9 points. Okay. This is the last slide of mine. The early detection of diagnosis, the hip dysplasia in young adult is very important to prevent or give a treatment before it turning to osteoarthritis. The relevant history and physical examination is the first key step to detect the dysplastic hip. In suspicion case, the further radiographic evaluation is mandatory. Okay. Thank you.